Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.
Welcome back to Pod Patrol with your host, Dr. Jeff Dykes.
And Dr. Leland Jaffe.
Today we are joined by Dr. Alan McGill down in Florida. How are you doing today, Alan?
I'm doing great.
Thanks for joining us today, spending some time with us on Pod Patrol.
Yeah, excited about it. Been listening to some episodes, so get a chance to partake.
Absolutely. So you went to the University of Florida and then Scholl College of Podiatric Medicine. You did your residency at Florida Hospital East Orlando, and then you spent some time out doing an AO trauma fellowship at University of Washington. And now you serve as podiatric surgeon at Spine and Orthopedic Center in South Florida, and you are the residency director at Northwest Medical Center. Kind of walk us through how you became a residency director.
Well, good question. When I first got into practice, I joined a podiatry group, and the person who I was working under started a program in the area. And I was involved a little bit as call it core faculty, and I was just a young practitioner trying to get cases. And during this time, watching a program grow and participating with the program and seeing things that you liked and maybe seeing things that, if I ever had the chance to do this, could I do them better? But it was great. It was awesome to continue to work with residency. Residency for me was a fantastic time. And I liked having that involvement. Fast forward 8 years later into my career, we opened up a satellite office across town. I got on staff at a hospital, and I remember I sat down with the CEO and I said, "Hey, I'm Alan McGill. I want to be involved in the program." And they said, "Great, fantastic. We'd love to have people to participate." So it just so happened that they had a change. The director ended up being terminated. They had an open call, and there was six or seven people who applied. And I remember in my interview, I went in and I said, "I love to teach. This is what I intend to do. These are the kinds of cases that I like." I said, "Whether you hire me or not, it really is not going to change a thing. I'm going to be here. I'm going to teach." And I don't know if that was what did it for me, but I don't think that everybody who went into that room said the same thing. They may have had, whether it was I need to be the director and it's because of X, Y, and Z, and if not, I may not be here. But I'd like to think that was something that played in my favor. And one thing led to another, and they said, we'd like to have you do it. And 7 years later, here I am.
That's great. Fantastic. So what are some of your favorite things about being a residency director, and what are some of the hard, we'll say the most challenging things of being a residency director? So the good and the bad of it.
The absolute best is a time that actually just passed. I mean, we had graduation. So when we're a relatively small program, I get 2 residents per year, and when graduation comes, it's so fulfilling. It's also bittersweet because you've seen these students, you know them as students. They come through, they can't find their butt with 2 hands. They're so green, and then to see the transition first year to second year to third year, and then knowing that you've hopefully prepared them to go into either private practice or fellowship, it's incredible. And I'm still friends with former residents who have come through. That's probably the most fulfilling. The most challenging for me is still trying to make what I would call a good hire. And as program directors, that's what we're doing. We're talent evaluators. And there are people who look good on paper, they shine on paper, but maybe that doesn't translate into the OR. And there may be people who don't look good on paper that completely surprise you. and translate very, very well in the OR. So, just going through all of this and trying to pick out who you think is going to be going to be the one, going to be someone who you can mold into a successful practitioner. That's still hard. I'm still learning.
Absolutely. Yeah, I mean, I can appreciate that. We just had graduation, and I work more on the student level, not the resident level. But to see them move on and just grow and mature from first year to fourth year is remarkable. I had residents with me day one in practice when I was in St. Louis. That's where I started, and I did want to make academia part of my career goals. I moved into an academic position about 5 years into practice. It sounds like you moved into this program director 8 years in. When along the way did you realize academics is really, what you want to make of your career path?
Oh gosh. So it's funny you say that, because I don't even think of myself as, someone rooted in academics. I'm not someone who is prolific in publishing. Yes, we do journal clubs. Yes, we try to stay up with the latest research, but that's just not me. I mean, I feel like I can teach the concepts, but I'm not the researcher. And I don't know if that's the question, but in terms of just academics, in terms of teaching and mentoring, I think that's maybe a better descriptor for me.
Absolutely.
I find the whole residency process interesting, because now, having been a student, a resident, I'm not a director, obviously, but kind of being on the other side of it, I'm not the first person to make this analogy, but it's kind of like dating, and you go up to a girl and you're kind of like, you kind of interested? No? All right. Well, I tried. And then you find someone who is interested in you, but maybe you're not interested in them. And you do this little dance where, you have some students that come through and they're your top students, and do they like you back? And maybe they do, and maybe they don't, but maybe they got their eye on a different pretty girl, a different program, or a handsome guy. So trying to make that kind of connection when it comes down to it is a little bit tricky. So have you found that to be kind of annoying, or how do you view that process when students come through and you're kind of courting them and they're courting you, and finding that match? I think maybe the answer is that it just kind of happens and it kind of works itself out, but how do you view that process?
You're right. Some of it's an organic process, but it's also a very difficult game for the residents. I don't envy that position at all. It's troublesome, because you can't. It's very hard to tell a program, you guys are good and you're in my top 5 or my top 3, because that translates to that program, we're not number 1. You have other people that you're looking at, and then automatically they may be bumped down a couple. So you have to play the game, but you have to be smart about playing the game. And however many years back, it happens every year where, it's such a small pond, and the residents talk and the students talk, and we may be told, well, we're so-and-so's number 1, but then we hear that, well, they just said that to the other program. And then that student is kind of, put on blast or whatever you want. And it's not a good look. So it's keeping in touch, I think, with programs that you're interested in. I tell these people all the time, if you come and extern with us in May and we literally don't hear from you until interviews, I have to assume that you really don't have any interest in my program. Even if you have some remote interest, shoot a text message, shoot an email, tune into a virtual academics. At least you're in sight, you're in mind, and I think that gives you a leg up. At least when January interviews roll around.
So I have a question on behalf of students, because I counsel students a lot on this particular topic. So how do students navigate that line between showing interest and being a little bit annoying or overbearing, or just showing too much eagerness towards a program? Like, it's a fine line, right?
It is a very fine line, and I don't know what the best answer for that is. I think that you kind of have to be able to read the room. That's that's part of this entire clerkship experience is, you spend 4 weeks just trying to get to know this family of people, the residents, the attendings, what you should say, what you should not say, feeling comfortable. And then you leave, you go to the next one, and you got to do it all over again. And it may be completely different at location B and then location C. So hopefully they can, learn to do that a little bit better each subsequent time.
Yeah, I always thought, when I was in Pittsburgh, we would have the students come through and then they want to know where they're ranked. And we always struggled trying to figure out, should we tell them or should we not tell them? Because we took 6 at the time. And if we told the top 6, they were happy. But instantly the number 7 person was like, well, I'm not in the top 6. I'm going to have to start looking around. And you're like, whoa. No, never does a program, I shouldn't say never. Very rarely does a program match. They're like 1, 2, 3, 4, 5. The more, spots there are, the harder it is to match all those people. So we always struggled trying to figure out, should we tell the students? Should we not tell the students? Because the people you tell in the top are happy, and the people who aren't in the top are instantly, you're going to maybe push them away when really they had a really good chance to match there. So I think it's just an interesting process. But I've always said that I think we have it figured out versus the allopathic programs that the students don't even really get a chance. I know people that visit for like a day, if they're lucky, to visit some of these programs, and they find out what specialty they matched in and where they matched. And it's just, where am I going? I'm going to Ohio, or I'm going to Oklahoma. It's just so, I wouldn't trade it. I think we have the whole process figured out. I don't know who designed or developed the clerkship program. Leland, you want to take any credit for that?
None. Okay.
I tried to give you a little bit of credit, but I think ultimately it is the good way that we do this. So let's move on. Let's talk a little bit about you being a triathlete. So how did you become kind of interested in those 3 events, we'll say, swimming, running, cycling?
Gosh, so I don't know if call it a midlife crisis. When I was younger and before kids, I used to play a lot of racquetball, and before that, golf. And of course, when you have kids, you can't just check out for 3, 4, 5, 6 hours at a time. But one of my practice partners said, you know what, we should start cycling. Let's do that. So we got on bikes and we rode, and we'd get tired after 10 miles, and then you try to do 20. And then the next thing he says to me is, we should do a sprint triathlon. And I said, that sounds ridiculous, because I'm not a swimmer. And it was just this concept that was so far out. And we signed up for one. And I remember the first time we did it, sprint's pretty short. But we're on the beach. It's freezing cold. It's raining. I thought that this was the worst idea in the world. And we did it, and we finished it. I think there was 3 of us, and you get out and you say, I can't wait to do it again.
I swear I've seen a lot of stuff in my life, but that was awesome.
And the minute I just got bit by the bug. So
nice. Was a sprint one where you each do one leg of the race, or you do it all together?
So that's a sprint relay, and they have that. But no, you do all 3. You swim, you bike, you run, and the distances are pretty short, and that's a good entry level kind of thing. And what it ended up being for me is that I would be able to wake up early. I could get in a workout, whether it's a run, whether it's getting on my bike and just riding, and it didn't really interfere with my workday, and it didn't really interfere with my family time.
Yeah, that's so impressive. Swimming is so hard. I'll swim to the other edge of the pool to grab another beer. But if I get out into a lake with other people kicking, I'm sinking to the bottom. That's so intimidating, seeing those people out there.
Step aside.
He just sunk like a stone, didn't he?
Yeah, I can't imagine. I mean, we have triathlons in Chicago and Lake Michigan, but I mean, the current, you're on the Atlantic side. I mean, that's got to be intense.
Yeah, and I like to swim in the pool, and I'll train. That's fun. You can see everything. It's controlled. And then when you get into open water and you're actually in the race, it's absolute misery. People are hitting you and you can't see anything. I'm swimming in a zigzag. I don't like that.
Hey! Watch where you kick it! You people find your own river! Ow! Ow! Jeez!
Yeah.
Yeah, when I was a resident, one of my attendings, he was an orthopedic surgeon. He got into cycling, and I mean, it became a religion. Like he would talk every Monday about the century bike rides he did every Sunday, and I mean, it was on a different level.
I
But
think
yeah,
maybe I'm just a little bit jealous. My wife is into ultra marathons. She ran a 50-mile race one time.
that's
It
impressive.
started at midnight. So I was inconvenienced because I had to wake up, drop her off at midnight, and then I had to go back to bed, and then I had to wake up early. So she was running literally the whole time, and I went back to bed, caught up on some Z's, and went back and saw her at the finish line. So I think I'm
That's
just a little bit
impressive.
jealous of the people that can do that type of stuff, because that's so far out of my wheelhouse. So that's fun though. I guess if you get good at it, then you enjoy it.
Yeah, I mean, I've done the Chicago Marathon. That's probably about the furthest I'll go. But I've tried to bike after running, or maybe the other way around. But man, it's tough. My legs would not work.
Yeah, it's super tough
Mhm.
for sure.
My friends tricked me into doing a 10K one time. They didn't really kind of explain what was going on, and I was miserable the whole time. So never
How do you
again.
get
I ran
tricked?
10K one time. It was more of like a, hey, let's go for they were training for a 10K, and then I was like,
Okay.
oh, I'll go for a run. And I was like, well, how far are we going to go? And they were like, oh, maybe just like a couple miles. I was like, all right, I can handle that. And then we kept running further and further and further away. And I was like, wait, we seem pretty far away from where we start. How far away are we? And they're like, don't worry about it. And I was like, well, now we got to get home. So it just tricked me into running further than I wanted to. So, Alan, you are involved with ACFAS. Tell us how you got involved with the American College of Foot and Ankle Surgeons.
Yeah, sure. When I was in residency, one of my mentors, one of my attendings was Dr. Chris Reeves, and he trained at West Penn, and one of the things what he told me at his program is that the people who were his mentors said one of the things you do when you're in residency is you join the college and you try to be involved and you try to get back to your profession, and that's was kind of ingrained at least during my training. So I remember when I first got out. I applied and I wanted to be on a committee, and I was fortunate enough to serve on a committee. I served on consumer education. It's probably entry level, but you do that for a couple years. You work up, you become the chair, and at some point you get asked to do some bigger roles. At some point, I think I got involved with the regions. I threw my name in the hat to be elected secretary treasurer, and then there's a succession. You end up being president of the Southeast region, and then after that, you sit on I became the chair of the regions, which gives you a seat at the board. And I was on the board for 2 years as the region's chair, and then kind of went the traditional way by being on the ballot and getting voted in after that. So it's been real fulfilling. I really enjoy working for the college and for the members, and just kind of seeing how it goes through the years. I mean, the changes in the profession, the fights that we fight. I mean, you guys see it. There's always challenges, and just being on that front is fulfilling.
Yeah, and you guys do a phenomenal job and inspire a lot of people. One of the best events we've had at our college in the last year was when the board of directors came and had their meeting in Chicago and got to interact with our students in the anatomy lab. And I mean, there was a buzz for weeks after that in terms of just the excitement, and just sometimes they can't see the forest through the trees, and they're stuck in the daily grind of classwork and boards and all the day-to-day work. But that kind of event really sparks excitement. So you guys are doing a great job.
Yeah, thanks. That's one of the things they do. We do our fall board meeting at one of the colleges, and this past year we got to hang with you, Leland, at Scholl, which is my alma mater. It was great to see everything. But the year before that, we were in Des Moines, and saw both campuses, which was just mind blowing. I mean, what they have going on in Des Moines. So and what's how big Scholl has grown. So it's nice to see the colleges.
Absolutely.
It's nice to see the growth of the field. I think it's a good sign. If campuses were diminishing and they weren't associated with other medical programs and they were dwindling in their numbers, I think that would be a bad sign, a bad outcome for the profession. To see that among not just our, Leland and I are biased with DMU and Shoal, but among all the colleges, seeing that growth, I think, is great. So what are your goals with the involvement of ACFAS? Because I view ACFAS as one of the kind of forefront leaders of education in our field. I mean, if anyone's ever been to those meetings, and I've been to the APMA National as well, and I'm not speaking ill of that at all, because I was impressed by that as well. But the ACFAS conference is very impressive. You show up to that, and the amount of time and effort and energy and the thought leaders that are involved in that, I think, is just great to see for our profession. So what are your goals with your involvement with ACFAS?
So what are the goals? One of the things I think is it is the preeminent organization for podiatric medical surgical education. And that's was my impression when I was a student, and I still feel that way strongly. Obviously, I'm biased, but for those students out there and for those residents who have never been to an annual scientific conference, I strongly encourage you to attend, because it is just a fantastic opportunity for surgical education, learning from the best in the field, seeing the latest and greatest in the technology of what's, in terms of the equipment and the implants that we use, networking, which is incredibly important to start even as a student, because like I said before, it is just an incredibly small profession. So to keep that going is something that I want to hope push that. There are a lot of other initiatives that I'd like to take credit for. I can't take credit for, but you guys may have heard of the registry, and it's not my brainchild. Some other board members have really gotten behind this, but the idea is to have this formal foot and ankle registry where we can track our patient outcomes, and we can build this data bank. So that we can publish our results, and we can combat some of these negative publications that come out. A lot of these bogus publications. So that's exciting, and that's just one of many things that the college does for the profession.
Yeah, I would second that in terms of students. Our students that go to the ACFAS conference have a phenomenal time. The networking and the relationships that they build over those few short days is remarkable too. So such a valuable event. Last year in Tampa was awesome. I'm excited to go out to Arizona next year as well too. So should be a great time.
Yeah, we always use it as an excuse to get together with all the old residents and see people from school. And there's a lot of times we're so spread out across the country that you don't get to see them very often. So it's almost like a built-in reunion as well. So we haven't made it the last couple of years. We've had some conflicts with family stuff. And then we tried to go to Austin, and we were connecting through Dallas, and our flight got canceled and rescheduled, and then canceled and rescheduled again, bumped to the next day. Then it got canceled again, and we were like, all right, never mind. Can't forget it. And it's not meant to be.
It was so cold during that one.
It was freezing.
Yeah, it was an ice storm in Dallas. That's all I remember. Yeah, and they were canceling
they had
flights.
To close sidewalks because they didn't have salt to salt the sidewalks.
Crazy. Yeah.
Yeah. I thought last year Jim Abbott did an awesome job as a keynote speaker. That was fun.
Yeah, that was great.
He's awesome. Yeah. So I'm looking forward to going to Phoenix this year. So we'll see you guys there. Anyways, how about we jump into some cases here?
Sounds good.
All right, let's jump into some cases here with Dr. McGill. Why don't you take it?
Yeah, sure. So I sent a couple over and tried to kind of keep a theme of just a little bit of acute deformity correction, closing wedges, if you will. But this first one is a 60-year-old male who had a history of a tibial fracture treated surgically quite a while ago. I can't remember, but has obvious gross deformity in the limb, pain in the ankle, and the lateral hindfoot. And I say pain in the ankle, but keep in mind, I mean, it's actually really good ankle joint range of motion. If you look at that AP, you can see that it does not look arthritic. It's in this congruent ankle valgus. And he had a lot of hindfoot symptoms. And what was interesting is he had kind of this flat foot, which was really hypermobile. And I have a video. I didn't send you the video, but there's a video of just a ton of motion and almost hypermobility around the TN and at the CCJ, which was also arthritic, had some osteophytes. So
this is really interesting here because it's almost baffling to me that the ankle can be congruous with that amount of tibial deformity. The compensation is obviously having to come from somewhere else, but usually see a tibial deformity, you're getting some ankle, at least some incongruity to the ankle. So to see a congruous ankle like that with that amount of tibial deformity is kind of crazy.
Right. And this was a healthy, slender, non-obese, pretty active person who was downhill skiing until the pain just got so bad.
So obviously we're looking here at correcting the tibial deformity. So what's your thought process when you see that tibial valgum there, that tibial curvature, and you're thinking, okay, I'm going to have to straighten that up. So what is your kind of stepwise approach for opening wedge versus closing wedge, considering, contralateral extremity length and limb length discrepancy, all that stuff. So what is your thought process when you think through how you're going to fix this?
Yeah. So in looking at kind of that AP on the left, ideally we want to try to correct deformity at the apex. And I think that this apex is probably a little bit higher than where I made my wedge. The problem that I envision is that I'm kind of getting out of that metaphyseal area, that rich metaphyseal, good healing zone. So I chose to make it right where you see those converging wires. I knew I have this multi-level deformity, so I obviously have to do a supramalleolar osteotomy that can get my limb straight, and then I can address the flat foot issue. The plan, I had to address the equinus, so I did that with the gastroc recession. I had done opening wedge osteotomies of the tibia from, believe it or not, a lateral approach, and that's just not fun. I struggled, and I didn't really want to struggle again. I thought that this would be much more predictable, so this was going to be a medial closing wedge.
Yeah, I think just utilization of whether it be an Evans, Dwyer, Cotton, DFWO, SMO, whatever we're talking about, whether we're talking about an opening or a closing, I find the opening wedge to be a lot trickier, especially up in the tibia when you're trying to think about, okay, what can I put in there? Am I going to put in some sort of a cage or an allograft, a fresh, something in there? What am I going to use to hold that out to length? With the closing, you don't have to worry about that. So when we get down into the Cottons and the Evans, they have these little wedges that kind of make it kind of dummy proof, that you just kind of make a cut and slide it right in there. But that's not the case for this. So you got good alignment there. Yeah, go ahead.
So just in terms of decision making, or I guess surgical planning, do you ever plan these out on any kind of apps where you can shift bone around and make some osteotomies on a digital platform and then correct it? I guess how much wedge do you need to remove? And I guess my second question is doing it acutely versus gradually with an external fixator or other. Can you talk through the decision making?
Absolutely. Great questions. And I've seen some of the software. I don't have access to any of it, and maybe I should, because I know some very cool stuff exists. What I do though, and what I have done, is just made old fashioned templates. I've used, printed paper, I've cut paper, I've drawn lines, I've kind of done it that old school way. The thought process, at least with this, was to try to get a wire perpendicular to the long axis of the tibia, and then the other wire parallel to the joint line. And then try to cut in between those. We can always take more. You don't want to make that first cut too massive, and then, God forbid, overcorrect. You may see in that little bottom X-ray there's that cut guide, and there's an industry, a company that has this set out, and we tried using it. We didn't have everything. It wasn't as user friendly as I liked. But I think with well-placed wires, this is the kind of thing that you can do by hand. Mm-hmm. I don't think you need a specific guide.
So you're addressing some of the flat foot component as well. You said there was hypermobility at the TN joint, and obviously the compensation of the tibial valgum is coming from somewhere, so it's coming somewhat within the foot. So talk us through your decision making there from the correcting the flat foot component.
Before I get to that, I didn't want to skip over Leland's second question. You asked about gradual correction, and I think that's useful. I don't know if that's as much in my wheelhouse as this acute correction would be. But I think that that's definitely valid. And there's a lot of people, I've got lots of colleagues, that's probably the first thing that they would go to. So back to the foot. I knew I had this hypermobile kind of abducted forefoot on the hind foot. The joint is arthritic, so I knew that I was not going to try to preserve it. It was going to be a joint destructive procedure. I needed length. I needed lateral column length. So that was going to be a distraction arthrodesis with a bone block. I think this patient also had the cotton. The TN was not arthritic. Some people could make the argument to do a TN fusion at the same time. I chose not to, but the cotton was helpful in bringing down that first ray and giving me some more medial column stability.
So with the final fixation here, you can see that the ankle sits in rectus alignment underneath the tibia. You've got a medial locking plate construct, a large 6.5, hard to tell, screw in the medial malleolus across your osteotomy, and then you did a fibular osteotomy to correct that as well. So the ankle joint mortise looks perfect there. So.
What's your post-op protocol with these types of osteotomies?
Non-weight bearing forever.
Forever, 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 ever, forever, ever.
No, no. I think with this, this was non-weight bearing for I believe 8 weeks, but before I felt comfortable doing protected weight bearing in a cam boot. Mm-hmm. Interestingly enough, this was a gentleman who was not in the immediate vicinity, and missed a couple of post-op appointments. And I remember calling and saying, I got to get you into the office. I got to x-ray this. And I would get I'm doing great. I'll come in like 2 months, which of course makes me lose sleep. But fortunately we didn't have any issues, with bone healing. He's doing fine. Just didn't follow my follow-up as much as I wanted him to.
So what was your thought here between doing the CC joint distraction arthrodesis versus an Evans? Did you say that the CC joint was arthritic at all, or what's your determining factor between those two lateral column lengthening procedures?
It was pretty strange. So when I would hold the hind foot and move the forefoot, you could see just a significant amount of hypermobility at that lateral column. And you could feel these bone spurs sticking out under the skin. So if I had more stability to that joint, maybe I would have considered an Evans. If that joint was healthier appearing on x-ray, I would have considered an Evans. I think that's an easier thing to heal, obviously, than this bone block CC fusion.
And what are your thoughts on using either a titanium wedge in there, kind of like an Evans graft, just putting it into the CC joint, because I've done that before, and then just press fit it and kind of let the pressure of the osteotomy, or in this case the arthrodesis, hold the wedge graft in place, versus using a bone product with an overlying plate. What's your thought process between those two options?
So it's interesting. I went through a phase where I was very high on the titanium wedge horse, and I thought that was the latest and greatest, and put a bunch in, and I had a couple of failures to where it didn't. I don't want to use the word incorporate, but the surrounding bone essentially collapsed around it. And when you have a failure around that titanium wedge and you have to salvage that, it's not fun. Explanting that and then putting in a larger either allograft or autogenous graft. So I think I got a little bit jaded after that, and I went back to allograft products. I don't hate it. I mean, I see tons of cases in post, but it's just not my cup of tea right now.
Yeah.
Is this one of those pre-cut allograft wedges that you have pre-selected the size beforehand, or is this a larger piece that you're cutting down to fit? Or what are you using for that bone allograft in that arthrodesis?
I can't remember offhand. I've been generally happy with the pre-cut wedges, but I also still really love the good old-fashioned tricortical iliac crest, because in residency that's all we had, and we would measure it, we would take out the wedge, and we would use the sagittal saw and just cut it to size, and it fit great, and it was structurally it was sound. I mean, they did not collapse. So that's still kind of the backup plan if these pre-cut grafts just don't fit or God forbid they kind of crumble as you're tamping them in.
Yeah,
So
absolutely.
looking at the tibia again, and the correction looks awesome. If you did have some degree of procurvatum or recurvatum in the tibia as well, would your approach have changed in terms of using the wire technique or using some other method? It becomes a little bit more complex when you're doing more of a biplanar correction.
Yeah, you were 100% right, and most of his deformity was uniplanar, at least in the distal tibia. But yeah, I think that you got to get pretty creative in the manner in which you make your wedge cut, so that you can correct in multiple planes as opposed to one.
All right, why don't you take us through this next case here? 83-year-old male, active and healthy 83-year-old.
Sounds good. Sounds good. So I like this case because this is a great example of chronological age versus physiologic age. So at face value, you see 83-year-old male, and you're thinking, this guy, this patient's got to be old and decrepit, and it was the complete opposite. I mean, this is someone who is very healthy, a laborer, the kind of person who tells you, I'm still, cutting my own yard, and I'm, doing heavy work. And this was an old fracture. It happened in his 20s, so you can imagine this is 60 plus years ago. Surgically treated. You can see a malunion of the distal fibula. There's obviously a screw placed in the medial malleolus. I have to envision that this at one point maybe was a vertical medial malfracture. And over the course of time has just kind of tipped into this varus, semi-congruent varus deformity, which is extremely arthritic. There's almost no motion. And this is the kind of person who literally has just been biting the bullet and working through pain for so long. Did everything conservative, injections, braces, shoes, you name it. And it just is at the point where, I'm 83 and I want to not have this pain. So, I've got this old screw. I've got this, really arthritic ankle. I've got this, varus deformity, and I'm thinking, what do I do with this? Because we know there's lots of options. You've got them listed here, but some of the options were, can I get away with a single stage TAR? I know that there are people, I've got colleagues who have talked about sliding vertical medial malleolar osteotomies to help with, varus ankles, and then maybe doing some kind of stemmed prosthesis, versus doing a stage procedure where you correct your alignment and then go back and then do the ankle replacement, or perhaps just doing a single stage ankle fusion. And I think what it boiled down for me was I did not want to prolong the recovery for this gentleman. And I also wanted to do something that I felt was most predictable for my skill set. And for that, this was an ankle fusion. It wasn't a TAR. I know that that's sometimes the sexy answer, but it wasn't in this case.
Yeah, I agree with you. I mean, I think that's pretty reproducible, reliable. You got to think about how old this guy is, his physical demands. Although active, it's still a relative activity level, not a 35-year-old activity level. It's still 80-plus-year-old activity level. So to be kind of in and out with one primary surgery, I think was very reasonable. So I think this part is very interesting. So there's people that are just listening, but why don't you talk us through what we're looking at here with that screw?
Well, so I'm trying to plan ahead, and I thought for sure I had to extract this screw. I thought that it was going to be in the way of my lateral hardware. So the first thing we did was take this screw out. Well, a 60-year-old screw, I have no idea what the screw head's going to be. Now, fortunately, there are a lot of companies who have these comprehensive screw removal sets, broken hardware removal sets, and we don't always have access to that. But I just remember when we got in there and looking at this, and number one, I don't think we had the right screwdriver. And then number two, this thing was locked in the bone. I mean, 60 years, I wasn't going to, it's not like where you can just do two like semi-twists forward and then the thing magically backs out. So getting the screw out, your next best thing, I think, is the trephine. And it's trying to select the right size and then line it up and then core around it. And that's kind of what we did just to get this thing out. And it was not easy. Sometimes there's a little pucker factor too when you're trying to get these things out. But fortunately, we were able to extract it. And that's just kind of a picture of what it looks like before we did our wedge resection.
Yeah, I think that can sometimes be the hardest part of a surgery. When you're doing revisional surgery, whether it's your own revision or someone else's revision, it's a lot harder when it's someone else's, let alone 60 years ago, because you're like, well, let's pull the op report. Well, good luck to you. It's
Right.
in a box somewhere in a hospital in, across the country somewhere, or if they even still have it. So good luck to you finding that, or even if they still make the dang head that fits through there. So I find it hard to plan ahead a little bit. Okay, was this a T10? Is it a T15? Is it a hex? Is it a something you get in there? You're like, that is not, I don't know what that is. I don't know what the heck that is, but that is going to be hard to get out of there. And then you say, all right, go get the screwdriver set. Okay, give me all the heads. And then you finally find one that fits in there. You're like, oh, great, this could be awesome. Yeah, and you go to turn it and it's nothing. And then you can feel it just start to strip the head.
Yeah.
And you're like, oh, okay, well, I found the right driver, but I'm never going to get this thing out of there. So that could be the most frustrating part of any surgery. So if I do my own revisions, it's fine. I know what screw that is. Okay, just pull that set. But old stuff or other people's, man, that could be a nightmare. You ever have to deal with that, Leland?
All the time. I mean, I had a case recently. A patient had a triple 20 years ago, so not even close to 60, but I didn't have the op report too. So you're going in there blind, and it can be humbling. So especially when the bone starts to grow over the screw and you're just trying to find the head, and in this particular patient, it was buried under like an inch and a half of just fibrotic chronic edema, lymphedema, brawny edema type tissue. It's just a needle in a haystack.
Yeah,
it's just a nightmare.
Patients will say, well, how long is it going to take? And I say, it's going to go really easy, or we're going to be there for a long, long time.
Exactly.
It's like, we have no idea. We'll find out.
And it's always an adventure. I remember back to residency, you're letting me at the time, the resident, try to do it, and you're kind of it can be daunting and exhausting to watch someone else struggle.
Yeah,
it's one thing to watch me struggle.
Oh, totally. I mean, I usually, if I'm taking out someone else's hardware, I usually keep the tourniquet down at least until I get the hardware out, and then maybe put it up just to save tourniquet time, because it can be a headache.
Yeah. I think the residents, the thing that they like the most is that when they're struggling and then I say, get out of the way, let me do it. And then they watch me struggle. They kind of grin in the back. They're like, see, it's not just me.
Yeah, that is the best. So similar concept here. You put those guide wires in. And I think that's a very important concept that you brought up on the last one, is putting one wire parallel to the talar dome and one perpendicular to the long shaft of the tibia. And if those are where they're supposed to be, then taking that wedge out is going to make those two planes align. So you've got the basically a do-it-yourself cut guide there. So that bone looks pretty terrible that you took out of there.
Yeah, it was bad, and the concern here too is whether or not after that bone came out, whether or not this thing would swing over. And I had kind of prepped in my mind that I may have to do some concomitant soft tissue work, and whether that's doing something with the PT tendon, whether it's a deltoid. I was hoping I didn't have to do a medial-malleolar osteotomy to just get the talus underneath the tibia, and I was fortunate. I was able to swing over without having to do a whole lot of that stuff.
Yeah, real quick before you jump into this, you brought up soft tissue, and one thing that kind of came to mind is when I'm swinging varus to valgus, I always think about the tarsal tunnel or the tibial nerve. Do you routinely release those, or should there be a thought process when you're going from varus to valgus?
Yeah, that's a great question. And you should absolutely have that in the back of your head. And I can't remember if I had consented him for that, thinking that could be an issue. Leland, there was a time when I knew about that concept, and I was a little bit of a disbeliever until I literally did a Capus foot reconstruction on someone, and the person was just saying, I'm like in so much pain. I'm in so much pain. And you're looking at the x-ray and you're saying, I don't understand why. Everything looks perfect. And then you go back and you do that tarsal tunnel release, and it's just like, that's what it was. So when you have that patient who has that, acute tarsal tunnel after your acute correction, you got to have that in the back of your head.
So you can see the planning here with the angles and all the fancy tools to kind of figure out where to go. But eventually you get to surgery and you just know, okay, this wire has to look like this. The other wire has to look like that. And as long as I put them there, then it's going to be in good alignment. So backing up a little bit here before we jump to what construct you did use, there are multiple approaches to ankle joint fusions. You have an anterior approach, you have an arthroscopic approach with cannulated screws, and then a lateral approach. I guess you could do a posterior approach, but most people don't do that. But a lateral approach here with a fibular takedown. So what's your determining factor for which approach you decided to choose and why?
Yeah, great question. I love to go anterior when I can go anterior. My concern with going anterior in this particular case is that I thought that my fibula was going to hold me up and that I would not be able to swing this thing closed without getting the fibula out of the way. So I kind of resigned myself to saying the only easy way to get this done would be to take the fibula out through a lateral approach.
Yeah, I think that's reasonable. And it's always harder to get the fibula out than you think. At least that's my experience. The number of ligamentous attachments of the distal fibula is unbelievable. You make your little osteotomy and you're like, all right, we're almost there. And no, you are just beginning. The number of ligamentous attachments that you have to circumferentially release of a distal fibula is crazy. So do you struggle to get those out, or kind of what's your technique to get the fibula out? Because I take a little pair of like crown and collar scissors and just kind of go around the edge of the fibula and work on it till it releases. What's your technique?
That works well. Sometimes a big curved osteotome to just try to get around that bottom corner. When you think about it, I mean, it's pretty barbaric too, just having to literally strip everything away off of that bone. Mm-hmm. But, it's a necessity in a case like this.
And it gives really, really good visualization of the joint, I've found, especially with one like this. You see that top right picture here where you've got the fibula takedown and the ankle is still in varus. I mean, you can see all aspects of the talus. So prepping here, although a lot of your quote-unquote prep is coming from the osteotomy itself, is just making flat cuts, so it doesn't really need to be prepped. But if you weren't doing that, the amount of visualization and prep that's available there is really easy with the lateral approach, I've found.
Yeah.
So here with the distal lateral fibular plate, it looks like your plate is riding superior to where you've made your fibular osteotomy. So are you sliding that up, or are you skirting that a little anterior? Because the fibula is going to sit a little bit posterior to the tibia. Are you sliding that plate a little anteriorly, or are you sliding it up between the two?
No, you're right. As it gets higher, that tibia gets narrow and gets a little bit more anterior, with the fibular shaft a little bit posterior. So there's just enough room. And I can't remember, but even if you do need to literally just use an instrument and pull that fibula out of the way a little bit, you can. It's pretty easy at that point, since the distal attachments have been disconnected.
So it looks like you've got good alignment there with your tibio-talar flat cuts, and then you've got this lateral base locking plate there with temporary fixation. Do you care much about getting compression, or are you just fixing it in situ, or what are your thoughts? Because with the weak bone, especially with the appearance of that bone that you took out of there, you get too much compression, you're going to tilt it back the other way, right? Because of weak bone. So are you just kind of are you doing any eccentric drilling or compression, or are you just kind of stabilizing it with the locking screws in situ?
Yeah, and this particular plate, I think, has an angled screw that allows you to throw in lag fashion. So generally, you'll fix the plate on one side and then lag across to gain your compression, and then the rest is really just drill and fill. So yeah, to answer your question, I definitely want to compress. Yeah.
So looks like here we've got significant improvement in the tibio-talar, no more varus. Good construct there with the multiple locking screws of the fibular takedown. That plate usually sits down pretty well. I've used this plate before with the tibio-talar, and it gets a little bit trickier when you're using the tibio-talocalcaneolateral plate with the fibular takedown. The plate that they have for that bows out a little bit when it gets down to the calcaneus, but I find it doesn't bow out enough, and I find myself resecting a lot of lateral calcaneus. So I did one of these the other day with a lateral approach, fibular takedown. And they had a previous subtalar joint fusion, so the subtalar joint was fused previously, but I wanted to put on a TTC lateral plate because they were going into valgus again. But I ended up using a posterior tibio-talar plate that sat down perfectly as a lateral plate with these extra little screws that aimed right down into the calcaneus. So
Nice.
sometimes you have to get a little bit creative, and sometimes the plate that you intend to use may or may not fit, especially when you start with anatomy. You look at the far left x-ray. That's not normal anatomy. A lot of the plates are built for quote unquote normal anatomy, or what the normal anatomy should be. And sometimes that's helpful. Like you said, your anterior approach, I find when I use the anterior ankle fusion plate, it almost puts it in the correct position for you, in the sagittal plane at least. So that one's great. But some of these you have to get a little bit creative. I was digging through the plates trying to find one. Okay, that one's not going to work. That one's not going to work. Let me see that one. Let me flip it around. Okay, was that a left or a right? Well, it doesn't matter. I'm just going to get that one on there. So just keep that in mind, that sometimes the plate that you intend to use from the get-go is not what you end up using, and having a little bit of flexibility from that standpoint is good. So was this guy happy with his outcome as he maintained his mobility?
Yeah, he is. He is. I think if I could be, critical of this, obviously I'm critical a lot of the stuff, but when you look at that lateral, I would have wanted that talus to be slid posteriorly a little bit more. That lateral process of the talus is a little bit more anterior. And I may have been able to do that if I wasn't doing this, closed hinge, but I didn't have the ability to just posteriorly translate it. But I didn't have any. Luckily, I didn't have any issues. Post-op complications. We got him up and moving. He's got an arthritic ankle on the other side, and not as bad, but at some point might have to address that if he wants.
In a healthy patient, I mean, he's 83, but you said really no medical history. Do you use any kind of biologics, bone augmenting type grafting with these kind of cases?
I do, especially in a patient like that. I think that it makes sense to stack the deck. And in this particular guy, we may have used the fibula and morselized it.
Right.
When you have these two opposing surfaces, I hate to just stick extra stuff in there, which may make it so that they're not well opposed. But for this case, I probably used platelet derived growth factor. Trade names, you guys know them all, but
Sure. So for this one, you used flat cuts because you're doing a corrective osteotomy. But let's say you were going to do either an anterior pro or any kind of ankle arthrodesis. What is your prep technique? Because I've moved from open curettage, which makes me sweat and want to lay down after the case, to like an MIS burr. Even if I'm doing an open approach, a lateral approach with a fibular takedown, I stick the MIS burr in there. But what's your approach now for preparatory, and maybe has it changed over the years?
Well, Jeff, your first problem is you need residents to do that because I don't sweat.
That's where I'm missing.
You just got to stand off to the side for 5 minutes, and kind of, and then you get in there and you get tired and then you tap out. No, I like the open curettage. I think from a training standpoint with residents, I think it's important for them to at least have that, to know what it feels like. That's something. Just literally scraping and grinding, getting the cartilage out and feeling the subchondral bone, being able to break up the subchondral plate. That's all important. So it's a combination of curettage, sometimes curved osteotomes, usually a 2.0 or 3.0 drill bit, depending on what joint, and really, really breaking that up. I really do, though, like the idea of the MIS burrs because that makes a lot of sense, even if you're using it from an open standpoint.
Yeah, I think in residency training, it makes a lot of sense because the feel and the sound, because sometimes you can't directly visualize. With this case, you have direct visualization of the ankle, but a lot of times you're prepping a subtalar joint or something where you're kind of sticking it in a deep, dark hole. You can't really see what you're doing. So getting to learn the feel and the sound of cartilage versus once the cartilage is gone, it has a different feel and a different sound of scraping on there with the curettage. I think that's an important skill to learn and be able to identify, because it's one thing to just be taught, MIS burr, okay, well then the thing broke, now what? Well, okay, I've never done a curettage. So I think that's absolutely reasonable in residency to have that sensation, to have that feeling. I remember back in residency, our residency director, Dr. Burns, would let us get in there with a curette and just scrape. And we're like, and he's like, "Are you think you're done?" And we're like, "Well, hold on, let me do a little bit more. And he's like, "All right, are you done?" And we're like, "Yeah, we're done." And he'd get in there and find like all this cartilage. He knew all the little secret spots where all the cartilage would hide. Oh, it's up there and over there. So learning that the hard way, I think, is helpful for the residents because it's just a good skill to have. So anyone listening who's in residency, if you're using an MIS burr, great. Put it down for a second. Pick up the curved curettes or the regular curettes and get to learn that feel, that sound, and what it's like to get the cartilage off there. What do you think about joint prep, Leland?
Yeah, I'm still a curette person. I'm probably causative for my carpal tunnel syndrome, but I don't have residents. I sometimes have students with me in the OR, but that would definitely be a luxury to have. But no, I totally agree. I think generating that tactile sensation of the difference between the density of cartilage, the density of subchondral bone is a valuable skill. So I like that technique as well.
And I agree with you with subchondral drilling. I always use a 2.5 or a 3.0 drill and get in there and just poke as many holes as I can. What are your guys? Do you have a thought process? Sometimes people would use a K-wire. I was always taught that a K-wire impacts it and a drill will extract it and so allow further bleeding through the hole. Do you guys have a thought process between K-wires or drill, Alan?
So I subscribe to all of that. Real world is that sometimes I say, all right, do you have the 2.0 drill or the 3.0 drill? And the answer is, it's not in this set. And if it's not, there's been times when I have used either a wire or a Steinman pin to get the job done. It's not first choice, but it's reality.
Leland, what do you think?
Yeah, I usually use like a 6.2 wire for the first MP joint or a smaller joint. If you're going to a bigger joint, then a small drill bit definitely works nice. And I'll usually grab a osteotome and kind of fish scale it too a little bit, trying to get some, breaking through with the osteotome and mallet as well.
I've always wondered if it actually mattered. I'd have to look it up. I don't know if there's any research comparing joint prep with K-wires versus drill. I can see both sides of it, but I think if you poke deep enough with the K-wire, you're still going to stimulate bleeding at some point.
Sure.
I think so.
Reasonable either way. So good correction there. We're looking at the pre and post corrective alignment of the ankle fusion that you just did here. So it's nice to be able to leave the OR. That's one of the benefits of surgeries like this. You can see such a significant difference. I don't like bunion surgery, but at least you can leave the OR and see such a correction in what you started with versus what you ended with. So it feels good to walk out of there with looking at how straight that is for this guy, knowing that you helped him.
Yeah, I'm laughing at this picture too because it's almost like if you don't get the best correction that you want, just put the dressing on and take a picture, and you can just let the viewers kind of insinuate that it's under there. But no, I fortunately I was happy with the correction and single stage and whatnot.
So what's your thought? We didn't talk 1 second because I do have a lot of younger people listening. What's your positioning, ideal position? This kind of goes out a window a little bit when you have such significant deformity or happen to get it into any kind of rectus alignment, just any kind of stable positioning. But typically speaking, do you have a position? Are you trying to align the tibial crest with the second metatarsal? Are you, do you have any thoughts? Not necessarily the book answer, but more so it's one thing to be like, oh, this many degrees. You're like, well, I don't have a tractograph. I'm not measuring. I'm just looking at the x-ray. So any thoughts, like you said, the lateral talar process under the tibia, but what are you aiming for there?
Yeah. So in terms of positioning that translation, I do ideally want to shorten the lever arm of the foot. I'd like to get that lateral talar process posterior of just a little bit, or at least a midline. That wasn't the case here, but there were bigger problems that we addressed. I think the biggest, at least pet peeve, or what I try to tell the residents, is the sagittal plane alignment. And, there's people who post lots of cases on social media, and, we see them all. I think that it's very easy to put these patients in a fused equinus position. I don't think that we necessarily dorsiflex them as much as we think we need to. So that's one of the things. And it's sometimes hard to get a perfect evaluation of that on the table. I mean, we try to use flat plates, and we step back, and I'll have kind of the residents, and we'll look from 15 feet away across the room just to see what that looks like. But that's an important thing. The other thing you talked about is the external rotation, and we know what the textbook answer, but I think you want to try to match the contralateral limb. And I'm not in a routine habit of draping out the contralateral side, but that's something that you can do. I mean, you can literally try to get a matching pair based on the non-affected limb.
I think that's reasonable. I think that's a reasonable approach. So that's one of the reasons kind of why we talked earlier about the anterior approach with that anterior plate. It's kind of dummy proof in terms of sagittal plane alignment, because that plate just kind of holds it right where you want it to be. It has been quite good for me so far. So when you do this lateral approach, you have good correction in the frontal plane, because it's preventing it from slipping into varus or valgus. But then it's on you to correct the translation and potentially the sagittal plane deformity. So there's a lot going on in there, and maybe it's lunchtime and you're thinking, man, I've got a couple hours on the tourniquet, and I'm joking, of course, but there's a lot going on there to pay attention to. And sometimes, I've been guilty of it. I'm sure many people have, where you start putting in screws because you get caught up on one radiographic angle, whether it be lateral AP, and you're kind of, oh yeah, you're measuring your screws, looks good. And then you take a lateral and you're like, that plate must have slid a little bit at some point. So, just trying to pay attention to all the stuff that's going on is tricky sometimes. So these are complicated cases.
And one other point, Jeff, is the decision between whether or not down the road you're going to consider doing a takedown to an implant later. You obviously need the fibula in place. This patient's 83, so that's not the case. But, the approach can certainly be based on whether or not you intend or will consider doing that later on.
Totally agree.
Yeah, good case there.
Yeah.
All right, let's wrap it up here. We've taken up enough of Alan's time. So thank you, Alan, for joining us today. We appreciate your time.
My pleasure. Thanks for doing the podcast and everything you guys do. I appreciate it.
Yeah, absolutely. If people want to reach out to you about your program, where can they find you?
Where can they find me? So I have an Instagram profile. It's just my name, Alan McGill, and I post cases. I post things that the program does. Obviously, our program is listed in the AACPM list of residency programs. It's HCA Florida Northwest in Southeast Florida.
Great.
Awesome.
So after this, I think there'll be quite a few more people interested in your program. So that's part of the goal of this podcast, is getting the word out. So thanks for sharing those cases with us as well.
Yeah, those were awesome cases. I think there's so many pearls and so many things people will take away. So really, really appreciate your expertise and your time.
Yeah, thank you.
Yep. So thanks for joining us on another episode of Pod Patrol, joined by Dr. Alan McGill. It's Jeff Dykes.
And Leland Jaffe.
All right, we'll see you guys. Always showing the Pod Patrol gear. Oh, I don't have anything. I'm the only one that I got a screen. I don't have any gear. All right, we'll see you guys next time.
Take care.
Take care.